I'm Loretta Nastoupil from the University of Texas, MD Anderson Cancer Center, and today I'm going to walk you through how to treat early relapse in a patient with follicular lymphoma. These are my disclosures. So we're going to kick off this discussion with a clinical case. This is a 75-year-old female with a history of follicular lymphoma, grade 3A. She presented 2 years prior with widespread lymphadenopathy, including a lymph node over 7 centimeters in size. Bone marrow was also involved at the time, hence stage 4 disease. She had a good ECOG performance status of 1. Labs were notable for LDH being greater than the upper limit of normal, as well as beta-2 microglobulin also being elevated. She had a high-risk Flippy score due to age, stage, elevated LDH, and number of nodal sites. At the time, she proceeds with bendamustine rituximab and actually results in a CR. This is her initial presenting PET scan, again demonstrating she's a high tumor burden and in need of therapy. 15 months later, despite achieving a complete response, she presents with recurrent palpable inguinal adenopathy, which you can see here on this PET scan. She has associated 15-pound weight loss, which is significant for her, and this has occurred within 6 months. A biopsy is pursued and confirms relapsed follicular lymphoma, grade 3A. So at this time, she's a 77-year-old female. She has recurrent follicular lymphoma, characterized as an early relapse occurring within 24 months of diagnosis and frontline chemoimmunotherapy. So how would you approach this patient? Well, based off of an observational cohort of the National Lymphocare that's been described by colleague Cassulo and validated in a number of data sets, we know that patients who experience an early progression event, defined as a progression within 24 months of chemoimmunotherapy, most of whom received R-CHOP. Again, this has been validated in a cohort of patients receiving bendamustine and rituximab. As outlined in this Kaplan-Meier curve, that blue line signifies these patients are facing poor outcomes with median overall survival far inferior to those who experience a progression event beyond the first 24 months. However, in the modern era where we utilize PET regularly, and in the Lymphocare, one of the limitations is that many of these patients did not undergo biopsy to exclude the possibility of transformation driving these poor outcomes. So another analysis put forward by Connie Lee at Memorial Sloan Kettering, if patients undergo biopsy and transformed disease is ruled out, which is often directed by PET scan, then it's likely closer to 10% of patients with follicular lymphoma who experience an early progression event, when we exclude about the 40% of patients where these poor outcomes are being driven by transformed disease. What's the data to inform our treatment selection? Well, the GADOLIN study was done in the second line or later space. It enrolled patients who were refractory to rituximab-containing frontline therapy. Now, I recognize bendamustine was the chemotherapy backbone in the GADOLIN study. And it was a randomized study of obinutuzumab in combination with bendamustine, followed by obinutuzumab maintenance versus bendamustine alone. And you can see by these Kaplan-Meier curves, there was a significant improvement in progression-free survival, as well as overall survival among the patients who had obinutuzumab in combination with bendamustine. Now, I recognize that this patient had had bendamustine frontline, so this is probably not my preferred approach, but does suggest you could potentially replace rituximab with an obinutuzumab-containing regimen to improve outcomes for these patients who have a shortened remission duration following rituximab-containing frontline. Can we exchange the bendamustine with a novel non-chemotherapy approach? There have been arguments put forward that an early progression event following chemoimmunotherapy would suggest that you might overcome those poor outcomes by changing the mechanism of action and trying a different approach. Lenalidomide is an oral immune modulator, therefore, when combined with a CD20 antibody, might be an optimal immune therapy approach for these patients. Based off of the AUGMENT study, patients who got lenalidomide in combination with rituximab had a superior progression-free survival than those who had rituximab alone. Now, this did select out for good risk patients, including those who were not refractory to rituximab, but also shown on this slide is the overall survival was significantly improved among the follicular lymphoma patients enrolled on this study who had lenalidomide in combination with rituximab, making this an attractive option in the first relapse setting. Again, as I mentioned, could we exchange the rituximab with obinutuzumab for those patients who are having early progression events or suboptimal duration remission? Well, the GALEN study, and similarly, we had a single-arm phase 2 study at MD Anderson, suggests very favorable outcomes with obinutuzumab in combination with lenalidomide in relapsed follicular lymphoma in a non-randomized single-arm phase 2 study. Outlined here are the early progression patients enrolled on the GALEN study, suggesting favorable overall response rate, favorable 2-year PFS and OS estimates among the patients enrolled in the study, again, who were treated with obinutuzumab in combination with lenalidomide, again, making this a potentially attractive option. What about the Pi3 kinase inhibitors? There are 4 currently approved in the United States for patients with relapsed follicular lymphoma, albeit in the 3rd or 4th line space, so maybe not appropriate currently for this patient who's only had 1 prior line of therapy. But a post-hoc analysis of the idelalisib study demonstrates, again, favorable outcomes among those patients enrolled on the single-arm phase 2 study who would have been characterized as an early relapsing patient. Again, seen here, no significant difference among those patients versus the general population, with a median PFS ranging from 8 to about 14 months in these patients. The Swog study is a randomized 3-arm study looking at, again, the various combinations I've described, a chemoimmunotherapy backbone, either bendamustine or CHOP, depending on what their frontline approach was, in combination with obinutuzumab, versus 2 targeted arms. 1 arm, including lenalidomide, based off the GALEN study, as we discussed, and the 3rd arm, a combination with umbralisib, which is the most recent FDA-approved Pi3 kinase inhibitor. This study is underway. It's slower to enroll than we'd like to see, so I'd make a plug for this trial. Any patients out there with an early event should be considered for this study to help us inform the optimal management strategy. Utilizing the agents that we have at least some signal would be an effective strategy in these early relapsing patients. Some of the most recent developments include the approval of tazemetostat, which is an oral EZH2 inhibitor based off of a single-arm phase 2 study. We know that 20 to 30% of patients with follicular lymphoma will have an EZH2 mutation, but based off of this study, we saw response rates, albeit different, higher among those with the EZH2 mutation than those with the wild type, though the PFS was about 11 versus nearly 14 months between these 2 groups, despite the widely varying response rates. Outline in this study, again, demonstrates activity with tazemetostat as a single agent, both in the EZH2 mutant and wild type cohorts among patients with an early relapsing event, designated here as a POD24 event, suggesting this too might be an option for these patients. It's currently approved in the US after 2 prior lines of therapy for EZH2 mutant patients, but for EZH2 wild type or unknown, if patients do not have an acceptable alternative, given that the safety profile of tazemetostat was so favorable, it could actually be considered. So I'll refresh your memory, we had a 75-year-old patient. We did not mention any significant comorbidities, but if there were concerns about her ability to tolerate more intensive therapies, this might be an option at this time, though I would like to know the EZH2 status in terms of my confidence about the depth of response. Another recent development is the approval of Axisell, which is an autologous CD19, CD28 co-stimulatory CAR T for the treatment of patients with relapsed follicular lymphoma after 2 prior lines of therapy. So again, not ideal for this patient who's currently facing 2nd line, but based off of this duration of response curve, we can see some of the most favorable PFS and duration of response we've seen thus far in the 3rd line or later space for patients with relapsed follicular lymphoma. And outlined here, there was no subgroup that did not receive benefit. And I'll highlight over half of the patients with follicular lymphoma were characterized as a POD24, suggesting that a CAR T might be a very encouraging option for patients in this high-risk group. Lastly, I'll mention the bispecific antibodies. This is specific to mosunetuzumab, which targets CD20 and CD3. We've seen reports of the phase 1 and now the expansion of single-agent mosun in the 3rd line or later space. And again, outlined on this curve is that we see activity across poor risk subgroups, including those POD24 patients, with an overall response rate reported at 76%. So again, we anticipate this will be an option, but probably in the 3rd line or later space. So back to our case, how would I approach the 77-year-old patient who's had an early relapse event following frontline bendamustine and rituximab? Well, my first preference would be to explore trial options, particularly given that we have novel agents that are being explored in that second line space. Outlined on this slide are some of the trials I have available to me currently at MD Anderson, which are targeted approaches incorporating some of the most novel therapies such as tazemetostat or tafasitamab, which is a naked CD19 antibody on the backbone of lenalidomide in combination with a CD20 antibody. We also have a CAR T-cell study enrolling these POD24 patients currently, JCAR, which appears to have one of the more favorable toxicity profiles. That might be an option. But for those of you who do not practice in the same setting that I do, what standard of care approach might you consider? Well, you have the option of chemotherapy in combination with the CD20 antibody, either rituximab or obinutuzumab. I probably would choose CHOP over a repeated course of bendamustine. However, given that this may not be well tolerated, again, if I've excluded the possibility of transform disease, I think your other options include lenalidomide in combination with rituximab, which has resulted in some of the most favorable outcomes we've seen thus far in that second line space. But for frail patients, again, if we don't know her EZH2 mutation status, and I've not reported it, I do think you can consider single agent tazemetostat, given the favorable PFS we've seen both across the wild type and mutant population. So with that, I appreciate your attention, and I'm happy to answer any questions.